We're in the site medical clinic today where a 29-year-old male has presented with what he states to be a migraine. It's lasted for longer than an hour. He says that he has a history of migraines, which he normally manages well with ibuprofen and or paracetamol, and occasionally ibuprofen plus codeine. The pain is unilateral in the right frontal region. He has slight photosensitivity. He's not nauseated and states that the migraine was a gradual onset today with his usual aura, consistent with recent migrainous headaches. He describes the pain as moderate. He has no known drug allergies and is otherwise well. His vitals have been assessed and are within normal parameters, and he's afebrile. His food intake today has been normal and he appears to be well hydrated. He has no neck stiffness. He's got no recent history of surgery, no recent trauma or significant preceding events today. His speech is normal with no dysphagia. He's fast negative and he mobilised into the clinic well on his own with no obvious difficulty and a normal gait. He is alert and orientated and freely given consent for physical assessment today. He has no personal or familial history of intracerebral bleeds and is not currently taking anticoagulant medication. Okay, Matt, so you've been experiencing this migraine for a little over an hour now, is that correct?
Yeah.
Okay. Are you finding the lights in here quite bright?
They're not too bad, they're
Okay.
alright, yeah.
If you feel like you can close your eyes, I'll just have to get you to open them every now and then for some of the assessments we'd like to do.
Yep.
So have you been otherwise well in the last week or so?
Yeah, look, nothing out of the ordinary.
Yeah, no head colds, no viral illnesses, no sinus problems?
No.
No. Okay. And is your headache today any different from your usual migraine or headache?
No, it's just real similar to ones I normally have.
Okay, and you had an aura today?
Yeah, I had a little bit of like blurry vision before.
Okay, does your vision feel quite normal now?
Yeah, no, it's not too bad now, it's good.
Okay, cool. Have you taken any analgesia or pain relief for this?
No, I haven't. I've left my medication at home.
Okay, what would you normally take for a migraine?
Normally I'll either just take just a Panadol or Nurofen or Nurofen Plus.
Oh, okay, so sometimes you take some codeine as well?
Yeah.
Okay, alright. Look, let's just do some physical assessments on you, just to see what's going on. If you just can sit forward for me.
Yep.
That's good. And just extend your head up and back, look up at the ceiling, and then touch your chin down to your chest, and then head from side to side. Okay, good. Just while you sit down, can you shrug your shoulders up for me? Great, and sit yourself back. Did you feel dizzy at all when you move your head from side to side?
No.
No ringing in your ears?
No.
No? Good. Alright, open your mouth wide for me, and poke your tongue up, down and up. Yep, great. Cool. Can you raise your brows? Yeah, cool, and scrunch them shut. Pop your cheeks out like this. Cool, alright. Just grab my fingers for me. Give me a good squeeze. Great, thank you. What we're doing here is just doing a rudimentary cranial nerve test.
Yep.
Making sure everything's working well.
Yep.
Just want to check your pupil reflexes with a little bit of light now. I'm sorry it's a bit bright.
Yep.
Good, just look straight at me.
Yep.
Good. And that's fine. Just want to palpate your face now, just let you know if it hurts anywhere. No problems with that?
No, it's fine.
Tell me, does this feel normal when I touch? Yeah.
Yep.
Feels normal to you?
Yeah, no, nothing out of the ordinary. Yeah, it's fine.
Great. Okay, just want you to track my finger now, so focus on the finger. Great. You can just look straight at me, keep looking in the middle of my head. Tell me which finger's moving.
That one, right.
And tell me which finger's moving now.
Left.
Now.
Right.
Now.
Left.
Great. Okay. So I can't see any significant problems with your assessment so far. Are you feeling nauseated at all?
No.
No? And you don't have any neck stiffness?
No.
Okay. Alright. What we can offer you is some analgesia. Would you like we can give you some paracetamol and some Nurofen if you like. I'd probably look to avoid giving you codeine because that can cause you some problems down the line with what's called a medication overuse headache.
Okay.
But that might be something you need to talk to your GP about. out.
Yeah, okay, alright.
We'll let you just rest and with the lights down low for about half an hour.
Yep.
See if your migraine abates.
Yep.
If it hasn't got any better, then we'll talk about maybe going to town to see the GP and discuss some other treatment options.
Okay.
How does that sound to you?
Yeah, no, sounds good.
All right. Do you have any questions at all?
No.
Are you happy with that treatment plan, or would you rather go to the hospital or see the doctor?
Yeah, no, I'm happy with that.
Yep.
Absolutely, sounds good.
We're back in the clinic again. A 29-year-old male has presented with epistaxis. The blood loss is minimal, however, it has continued for over 45 minutes now. Upon assessment, his observations are all within normal parameters. He has no known drug allergies, he has no significant medical history, no clotting disorders, and is otherwise fit and well. He takes no regular medications and certainly no anticoagulants. He suffered no trauma and has had no recent surgery. He has been sitting upright and leaning forward in the clinic now for the last 15 minutes, pinching his knees, but his left nostril continues to bleed. I've advised him that I'd like to administer intranasal adrenaline as a vasoconstrictor to help stop the bleeding, and he's given his consent for this procedure. Okay, I'll now demonstrate the correct procedure for drawing up the solution of 1 in 10,000 adrenaline for administration via the MAD or mucosal atomizer device. So we have a 10 ml syringe, a 3 ml syringe, a non-bevel drawing up needle, 1 milligram of 1 in 1,000 adrenaline, 10 ml of normal saline, and an MAD. First thing we'll do, draw up 9 ml of normal saline. Do the best we can to assure asepsis. Place the drawing up needle on there. Again, drug checks have been carried out to ensure it's the correct drug within its expiry date. Placing sharps in sharps container. And draw up the adrenaline. Sharps away. Now have a 1 in 10,000 solution of adrenaline. And excuse me, we need 2 ml of adrenaline. For administration. Alright mate, so it's been just over 15 minutes now, and you've still been bleeding even though you've been pinching your nose.
Yeah.
So I've got the 2 ml of adrenaline which we've discussed, which I'm going to inject up your nose. It's going to atomize, and the idea is that it will constrict all the blood vessels and stop that nosebleed. So if you want to take your hand away now.
Yeah.
Great. And just put your head back for me. And just as I do this, just breathe in. Great. And then just pinch your nose and lean forward again for me. Yeah. And we'll just wait for another 15 minutes.
Yeah.
Okay, Matt. So it's been 15 minutes, and it looks like we've had some success with that adrenaline, stopping that bleed.
Yep.
Okay. How are you feeling now?
Yeah, much better.
Okay.
Yep.
Great. Look, I'm happy that we've got that under control and there's no immediate need to go to the hospital. You've got no significant risk factors that would require that. I do think it's probably a good idea that we make an appointment for you to see the GP up the road.
Yep.
And see if there's anything else that the GP would recommend.
Okay.
Do you have any questions or any concerns for me?
No, it's still good.
Okay. Just the main things to remember before you see the GP are not to blow your nose, try and avoid any hot drinks or hot showers, and don't pick your nose either.
Try.
Right.
Yeah, no worries.
We're back in the clinic where a 29-year-old male has presented with an acute lower back strain after lifting heavy equipment into one of the vehicles today. He does have a history of a back injury 2 years ago in the workplace, which he described as a strain. It was well managed with physio and rehab, and he resumed duties freely with occasional flare-ups. He's mobilising well, but does appear to be in some discomfort and appears a little stiff. He describes the pain as somewhere between mild and moderate and is interfering with his duties. He describes it as an ache, not sharp. Now the pain is localised in the lower back and there is no sciatica. He's otherwise fit and well. His vitals have been taken and are within normal parameters, and he's afebrile. He states he has no known drug allergies. Usually when experiencing an episode of back pain, he takes ibuprofen with good effect. His food and fluid intake today have been normal. He states he has not had any problems with or loss of normal bowel or bladder function, and has not experienced any numbness or altered sensation in the saddle region or any sexual dysfunction, so cauda equina syndrome is unlikely. There's no other known preceding factors or episodes today, and he's had no changes in his usual gym routine. He's freely given consent to be assessed today. Okay, Matt, so you're complaining of some pain in your lower back or your lumbar region of your back, is that right?
Yeah, just lower back here. So yeah, really quite sore.
Okay, and is that similar to the previous injury you've had before?
Yeah, it is.
Okay.
Yeah, it's recurring.
Better, worse, or much the same?
Oh, look, much the same.
Much the same. Okay. All right. So what we'll do is we'll get you to lift up your shirt and we'll have a quick exam of your back.
Yep.
All right, Matt. So what we'll just do, mate, is check out your back by palpating it or feeling your spine and also your muscles to let me know where it hurts.
Okay.
So we'll palpate down your spine to make sure there's no bony tenderness on the actual spine itself. Is that all right?
Yeah, that's fine.
Okay. Good. And also the muscular area beside the spine?
Yeah, it's a little tender down there.
Just tender in this region here?
Yeah.
Okay. Still tender as I go up?
No.
No? So really just in this area here?
Yep.
Alright, so we just also want to rule out there's no rashes, discoloration or spasms. Have you felt like your back spasmed at all?
No.
No? Okay, good. The other thing we need to do is just check for any flank pain. So we've got no issues there. That's good. So really just complaining of a lateral lumbar pain, really on those extensors, and it looks to be around that sort of L3, L4 region. Okay. What we'll do, mate, is just get you to lie down, mate.
Sure.
Cool. Also, mate, just want to feel your tummy.
Yep.
Just make sure it's soft and non-tender to make sure there's no problems in your tummy which are causing problems with your back.
Yep.
Okay, so Matt, when you're lying down flat like this, does your pain feel better or worse?
Better.
Bit better when you're lying flat?
Yeah.
Okay, that's good. Now, sensation-wise, have you got normal sensation in your legs?
Yep.
Yep. Good. Move both your feet for me. Great. Just, if you can, push against my hands. Does that aggravate the pain in your back?
No.
Oh, good. And just pull up against my hands. Again, does that aggravate the pain?
No.
Okay, good. Can you raise your left leg up off the bed, please? Good. And your right leg? Does that cause you a little bit of extra pain in your lower back when you do that?
Oh, it's the tiniest bit, but
Okay.
it's bearable.
Yeah.
Yep.
Good. Excellent. Okay, what again, mate? I'll just get you to sit up again if you can.
Yep.
How does that feel?
Yeah, no, it's not too bad.
Okay. All right, mate. So after those assessments, I'm reasonably happy that there's no significant injury there, and it's probably just a recurrence of your original back strain or another back strain from the activities you've done today.
Yep.
How do you feel about pain relief?
Yeah, just if you do have something,
You certainly can.
just
What we can provide you with is some ibuprofen.
Yep. Okay.
And perhaps also if you felt like you needed some paracetamol.
Mhm.
How bad is it, do you feel at the moment?
Oh, look, it's a noticeable sort of pain, so it's not excruciating pain or anything, but it's sort of enough to sort of keep me a little bit distracted.
Okay, all right. Well, look, we'll give you 400 milligrams of ibuprofen.
Yeah.
No problems with ibuprofen in the past?
No, I've used it before in the past. And
Okay.
And what we'll do is we'll also make you an appointment to see the GP, just so we can get you involved in the fit to return to work process,
Okay.
and get you a certificate if you need it.
Mm-hmm.
As well as that, I'll get the site physiotherapist involved,
Mm-hmm.
just to make sure that we're doing the best we can for you.
Okay.
Have you got any concerns around that?
No, it all sounds pretty good.
Okay, anything else we can do for you?
No, that's it. Fix my back.
Alright, we'll go and make an appointment for you to see the GP, and we'll
Cool.
write up the necessary documentation and
Yep.
make it happen.
Alright, cheers, appreciate it.
Once again, I'm back in the clinic. A 29-year-old male has presented after climbing down from a truck onto an uneven surface and rolling his ankle. Secondary survey assessment has found no other injuries, just an isolated left ankle inversion injury. He states he was able to weight bear at the time of the injury and has also walked, although in some discomfort, into the clinic on his own. The pain is moderate and constant. He's otherwise well, takes no regular medication, and has no known drug allergies. All his observations are within normal parameters, and he has given his consent to be assessed and treated for this injury.
Okay, Matt, so now we're going to assess your ankle.
Yep.
And try and figure out exactly what you've done to it.
Mm-hmm.
For the sake of examination, we need to expose both the feet, even though Matt's had his work boots on now for several hours. But it's okay, you put fresh socks on today.
Yeah, surely just for you.
Nice. So comparing the injured ankle to the non-injured ankle, we're looking for any gross deformity, discoloration, bruising, or any wounds or breakage in the skin. We can see there's some swelling, particularly to the lateral aspect of the ankle, and a little bit of bruising starting to come out there as well. The next thing we want to do is check for circulation, so we'll assess Matt's pedal pulses, which are good and strong. Good, and then the limb observations, so we're going to check for colour. Colour looks good, warmth's good. Sensation, can you feel me doing that?
Yeah.
Yeah, quite ticklish.
Yeah, just a tad.
Capillary refill is good. And you just able to wiggle your toes for me. And how about move your foot for me?
Yeah.
Where's that hurting when you do that?
Oh, it's just a little tight in the ankle there.
Around the outside or the inside?
Yeah, mostly, the outside.
Mostly around here?
Yeah.
Is that tender when I touch in there?
Yeah.
A little bit?
Yeah.
Right up around this area here?
Yeah.
Okay. So the next thing we need to do is also perform a differential diagnosis to rule out a ankle fracture. So we'll apply the Ottawa rule. For the malleolar zone, we need to assess whether there's any bony tenderness on palpation for the posterior tip of the medial and lateral malleolus. Are those tender when I touch on there?
Yeah, not too bad.
No tenderness?
No,
No?
that's
Okay.
all good.
Good. And also we're assessing Matt's ability to weight bear. So you walked on this ankle straight after the injury.
Yeah.
And Matt walked into the clinic, so I'm happy with that. The other area we assess is the midfoot zone. And so again, we're looking for any bony tenderness on palpation to the base of the fifth metatarsal, as well as the navicular, and again applying the weight bearing rule. So based on that, Matt, I'm happy that you most likely don't have a fracture either in the midfoot zone or the malleolar zone.
Mm-hmm.
And so you don't need any x-rays at the moment.
Okay.
Now, sensation wise, can you feel that quite normally?
Yeah.
That feels good. That's all right?
Yeah.
Okay. All right. So what I think is you've got is hopefully a relatively simple sprain,
Mm-hmm.
just in this region around through here.
Mm-hmm.
What we'll do is provide you with some pain relief.
Yep.
We'll ice it, keep it elevated for a little while, and also apply some compression in the form of a tubey bandage.
Mm-hmm.
You're all right taking paracetamol and ibuprofen or Nurofen?
Yeah, I've had it before.
Yep. Okay. So what we'll do is we'll give you a gram of paracetamol.
Yep.
And we'll also give you 400 milligrams of ibuprofen at the same time. And I think what we'll do is, seeing it's a work-related injury, we'll give the GP a call and make an appointment for you,
Mm-hmm.
and get you into town so he can assess you and organise sick certificate, and then he can get involved in fitness to return to work stuff.
Yeah.
As well as that, we'll get the site physio involved for any rehab that you might require in your return to work.
Okay.
Have you got any questions at all?
No. Sounds sounds pretty straightforward.
Any concerns? No problems?
No, just getting back to work.
Okay.
It's all good.
That's all right, and we'll get you to come back and we'll check up on your progress as well.
Yep.
All right.
All right. Sounds good.